more common things that we see that don't require surgery. So without further ado, we will attempt to share our screen here. Okay. So my disclosures are listed and they're non-relevant to this particular talk. Our objectives today is we're going to learn some common sports injuries in pediatric patients. We're going to discuss some diagnostic protocol of injuries to a growing skeleton and describe the management of some common sports injuries. So as many of you know and probably are involved in, sports are a key part of childhood today. Many kids participate in youth sports and it's a very important part of their childhood years. There's many benefits to sports, physical, psychological, social benefits. A lot of us who are in orthopedic surgery were at one time athletes. We feel like some of us still are athletes, but sports have become very important to us, and kids, we see a lot of kids who are participating in sports now. So here's just a chart from a few years ago demonstrating sports participation rates, and you can see the majority of kids participate in some type of sport, whether that's a team sport, an individual sport, and a regular basis. You can see that almost 40% of kids are participating on a regular basis at some point. So in a few years ago in Kentucky, there were 106,000 high school kids that participated in sports. This is just high school only, and 13,000 of those were in football. That included 33 females that played high school football. So youth sports can start as early as 3 to 4 years of age with youth soccer and some other sports like that. Many kids will play sports, therefore, for 10 plus years of their childhood, all the way from being almost a toddler into high school and perhaps beyond. And sports and athletes in particular are highly valued in American culture, especially now with not having a lot of live sports, and baseball and basketball have obviously started a little bit, but now that we haven't had live sports for a while, they're definitely something that a lot of us miss. So sports also carry an inherent risk of injury. I put in some other activities such as art, music, and theater that kids can be involved in that really don't have necessarily that same risk of injury that sports do. So some different injury patterns. That's one thing in children that are different than adults from an injury pattern standpoint, is they are age dependent. So a 4-year-old does not get an ACL tear. They get other injuries as opposed to a 17-year-old who's essentially done growing that doesn't get, say, a growth plate injury or growth plate fracture. So many of the sports injuries that people are familiar with in adults don't happen very often in kids, especially young kids, because their tissues and their growing skeleton often are different. So when we think about sports injuries, we kind of look at different sports, and they're dependent on, or their injuries can be dependent on what sport they're playing. For example, you see some examples here of soccer as more of a knee and ankle kind of injuries. Football, obviously, we are dealing with concussions a lot now, and arm and knee injuries. Baseball injuries, it's more common to have shoulder and elbow injuries, or sometimes trunk injuries from the swing. So some different injury types. We'll talk some about overuse injuries, which are very common in kids. We'll talk about some strains and sprains, and we'll talk about some fractures, which is something we commonly see. So overuse injuries, and I think for the primary care physicians or primary care providers that may be on today, this is something that you are definitely going to see a lot in your office. I'm sure you have already. This, interestingly enough, I would say this spring and summer, we probably as a group have not been seeing as many of these overuse injuries because of the lack of organized sporting activities because of the pandemic. So, but they are becoming more and more common. Sports participation is obviously on the rise, and sports are starting at an earlier age. And we also deal with something called too much specialization. So a lot of these kids nowadays are specializing in one sport and playing that year round. Whereas, say, when I was growing up, we played sports depending on the season. If it was basketball season, we played basketball. In summertime, we played baseball or played golf or ran track and things. And nowadays, you have kids that are doing one sport chiefly throughout the year. So many of these overuse injuries are due to stress on a growing skeleton, and this often affects the growth centers or the growth plates. And I want to spend a little time talking about those because growth plate injuries are something we commonly see, and I think a lot of people might have some questions about. So the growth plate is an organized line of cartilage and growing bones. And I'm not sure if you can see my mouse, hopefully you can, but this line here at the ends of these bones is the growth plate or the growth cartilage. And each bone has 1 or 2 growth plates. And the growth cartilage or the growth plate has specific functional zones. And so this photomicrograph here kind of shows the zones of what's called the physis or the growth plate. And that goes from a zone of resting cartilage as it follows it down all the way to where it gets replaced by bone as the child grows. And so this gives you both longitudinal growth and circumferential growth. And these are easier to injure oftentimes in kids because they are a weaker part of the bone. They're not as solid as the actual bony calcified tissue. And so these areas can oftentimes be injured. So there's a lot of different names for some of these growth plate overuse, I'll say injuries or maybe syndromes. You can see those listed: gymnast wrist, little league shoulder and elbow, jumper's knee, Seaver's disease or Seaver's syndrome, which is at the heel. So we'll talk a little bit about each of these, but some common features with all of them: they have pain with activity. Usually once they rest or they stop playing, their pain goes away. Sometimes after play, they can have some increased pain for a short time. They might have some mild swelling, but they usually don't have an acute injury. It's something that kind of just is more of an insidious onset. It just kind of starts to happen as they are active. So gymnast wrist is a repetitive impact on the distal radius, and these x-rays here show some arrows showing where the growth plate at the distal radius is a little bit wider and a little bit irregular, and that's just from chronic repetitive landing, tumbling, vaulting. And you can see here, this picture off of Google shows a girl vaulting, and she has these wrist protectors, which we'll talk about a little bit in a moment, but that can be very helpful. But just chronic repetitive pounding essentially on the growing wrist is what gives you gymnast wrist. Little league shoulder and elbow is caused by repetitive throwing. So pitchers, catchers obviously are the most susceptible to this, but any position that does a lot of throwing is pretty classic for this. And specific pitches such as curveballs can put more stress on the growing elbow than other types. So an example of little league shoulder you see on the side here, which is on the left side of the screen, a little league shoulder that has, again, some widening and irregularity of the growth plate with the little blue arrow there, compared to what would be a normal growth plate of the upper humerus, which is that x-ray on, or the picture on the right. So, and again, little league elbow is chronic stress on the medial or the inside of the elbow. And you can see in this picture with this child who has the ball kind of in behind him at what we call late cocking phase of the throwing motion, that puts some tremendous stress on the inside portion of the elbow as that arm comes through to give you the velocity of throwing. And these kids are throwing harder sometimes than their elbow can take. And again, what you see is kind of a common feature: some weakening, some widening of the growth plate there where that arrow is, a little bit of perhaps separation of that area of the growing bone there. That's a normal growth plate on the right, and then abnormal growth plate on the left. So that brings us to some examples of some pitching rules. Obviously, these are a little bit dated, but they are still relevant now. The baseball guidelines and Little League Baseball for a number of pitches a day and weekly limits. And a good Little League organization and coach should be adhering to these pitch guidelines, as you can see listed, and these are easily found on the internet. One issue that sometimes we run into is that kids will cheat a little bit by playing on, say, multiple teams. They might play on their Little League team and then their travel ball team, and the coaches might be different, and so they kind of can get around these pitch and throwing guidelines a little bit because of multiple teams. So just something to be aware of. So jumper's knee is another common thing. This is also called Syndig-Larsen-Johansson syndrome, or SLJ, but jumper's knee is a little easier to say. So this is pain at the inferior pole of the patella, and it's typically while running or jumping, And this MRI scan here shows a little bit of edema and some signal at the bottom of the kneecap, of the patella, and that shows that it's not separated, it's not torn, it's just a little bit inflamed there and a little bit unhappy. So typically running and jumping sports, such as basketball, track and field, would be your most common. Sever's syndrome, this is something I'm sure every primary care provider who's on here today has probably seen in their practice, which is pain at the heel. So it can be at the Achilles tendon insertion, so at the top of the heel bone. It could also be a little more on the bottom of the heel or sometimes on the sides. And so squeezing the heel or pushing on the heel bone can essentially give you that diagnosis in a kid who has some heel pain with activity that's otherwise uninjured. And the nice thing that I usually tell parents is that there's very few things in kids that have insidious onset heel pain with normal x-rays that it can be besides Sever's syndrome or Sever's disease. So some common treatments. You'll notice I have rest in here multiple times. And so that's really the most common form and the best form of treatment is rest from the offending activity. Ice and anti-inflammatories are also very useful, but sometimes a formal period of rest is needed to get the pain to calm down. Specific treatments would be stopping tumbling, stopping throwing, stopping jumping. This is very difficult in a kid, and that's why you have an angry kid picture here. They're very, both either the parents or the child may be pretty unhappy by telling me, hey, you need to shut this down for 2 weeks, sometimes 4 weeks, depending on the injury and depending on the severity of their symptoms. So sometimes 4 to 6 weeks is needed for a full period of rest. And that's why one of our doctors that used to be here, Dr. Chan, used to say even the pros have an off season. Doesn't mean they don't work out or practice, but they do cross training, they do some other things. So kids need an off season. And so sometimes that forced rest is what's needed. Treatments can include braces, straps, pads, immobilization. So when we talked about that girl vaulting, these are called tiger paws. It's not a endorsement of any product. That's just a name for this type of wrist support. This is what's called a Chopat strap. So that puts some pressure on the patellar tendon to try and decrease the pressure at its insertion to the bone. These are some soft heel cups on the bottom that we use for Sever's disease. And that just gives them a little gel cushion or padding over the heel to try and decrease their pain. So we talked a little bit about sports specialization. This is becoming more of an issue. More people are writing about it, doing studies on it, those kinds of things, realizing that this is leading to some more overuse injuries. And so it overloads joints and muscle groups. So for example, if all you do every month is play baseball and throw and things, you are definitely overloading some certain muscle groups and certain joints that you wouldn't be doing if you did other things in addition to throwing. So in this travel teams, select teams, school teams, we hear lots of stories about kids who want to play on their high school team, but can only do that if they play on the travel team during summertime. And that's fine. And some kids can handle all of that sporting activity and some kids can't. So you may have a child, either that's your own child or somebody you see in your practice that has, say, one of these overuse injuries, and they say, well, my teammates don't have this and they're doing the same thing I do. Well, that's true. And so sometimes it's difficult to say why one kid might get an overuse injury or problem and another might not. It may have a lot of multivariable factors. So what we like to do is encourage cross training. So I always have to get my kids into one of these talks. So that's my son who's behind the drums and my daughter who really is into theater. They like sports. They're not athletes. And so they did their little bit of sports when they were growing up, but they found some other things that they really enjoy. And so non-sporting activities are also important and can bring a lot of those same kinds of benefits to kids. Individual and team sports. When I was even in high school and college, I played golf and ran track. And those were great sports, I thought, from an individual standpoint, but also as part of a team. So you could kind of get some benefits from that and encourage multiple sports, encourage some different types of activities or different sports as opposed to maybe one sport year round. Okay, so that's overuse injuries. Now we're going to talk about some fractures. As an orthopedic surgeon, that's a lot of what we see. And these can be simple or complex depending on the severity of the offending mechanism and the age and things like that. So, but I want to talk a little bit about some growth plate fractures. The most common growth plate fractures we see are around the wrist and around the ankle, or specifically the distal fibula on the lateral side. So there is a Salter-Harris classification, and that's the classification of growth plate injuries, and it's 1 through 5. And Salter 1 is by far the most common that we see. And so usually these are not a significant injury. Well, I'll show you an x-ray in a minute that is a more significant injury, but the growth plate, again, is softer than the surrounding bone. That cartilage is softer than the surrounding bone, so it may be easier to be injured. The great majority of these do not cause long-term growth problems. That's a common worry from a parent, a child, maybe a referring physician, that these might cause problems with long-term growth, and that's very, very uncommon. And it's really only an issue when the growth plate has been severely disrupted or damaged, and you will see that on the x-ray here in a minute. So the x-rays are very often normal. You don't really see anything on the x-ray to point to the parents and say, aha, here's the injury right here. So it's usually a mild or a moderate injury mechanism. That could be, I was walking the dog and I fell. I fell off the swing and landed on my wrist, and it is swollen and it hurts. Usually these have localized pain and swelling over the area, and tenderness over the growth plate is what we look for on exam. So here's an example of essentially a normal kid's wrist, a couple different x-rays where you see what appears to be a normal growth plate. That blue arrow is simply pointing at the growth plate. There's no other visible evidence of injury or damage on the x-ray. There's no visible fracture line. There's no separation. But this child may have swelling and acute tenderness directly over that spot. So as opposed to these x-rays where the bone itself is not visibly fractured through the bony, say, material or the bony tissue, but it's slid off through the growth plate. And so this is an injury that does require at least a reduction or a straightening and casting, and may be a little more prone to a growth plate problem long-term, which we simply will follow. But if there's no evidence of displacement on the initial x-rays, there is really no chance of any growth arrest or growth problems going forward. So here's an example of a distal fibula growth plate fracture. Again, the ankle joint is normal. The alignment of the bones is normal. You simply see a large amount of soft tissue swelling directly lateral to that growth plate. And in a younger kid, usually 10 and under, I wrote, that's very rare to be a sprain. It's typically an actual growth plate injury. A teenager, sure, an ankle sprain is very likely, but in a younger kid, a growth plate fracture, because they'll be more tender over the bone than they will over the ligaments. And so we treat these with a boot or a walking cast for 3 to 4 weeks, simply a below the leg cast. So that's growth plate fractures. And again, at the end of the talk, we'll have some time for questions and things like that, so we can go through that more if we need to. So sprains and strains, again, we talked about that 4-year-olds typically don't get sprains. Okay, this is be more of like your high school athletes, your teenage athletes. A sprain is a ligament injury, a strain is a muscle or tendon injury. And so again, these are more common in the teenagers or skeletally mature patients. On average, should mention this, girls' bones grow and mature until the age of 14, and boys usually till the age of 16. Now that's an average. So you might see a 16 or 17-year-old female that essentially has adult bones and can have adult type injuries. So again, treatment for sprains and strains oftentimes is brief immobilization, so maybe 1 to 2 weeks in a boot or a brace, something like that. It's gradual return to activity, and these are oftentimes where physical therapy can be very beneficial. Especially for recurrent ankle sprains, for example. Physical therapy can do a very good job of decreasing that rate of recurrent injury to the ankle. So we'll use physical therapy quite often in sports injuries. It's a huge part of recovery for sports injuries, especially in older kids. Even younger kids can definitely benefit from therapy, but we don't typically send 3-year-olds to therapy for a lot of these things, because they essentially do their own therapy. They start walking once their immobilization's off and they're out of their cast or something, and they really do their own therapy. as far as return to play, therapy is very helpful for proprioception and balance, kind of knowing where your foot or your leg is in space so that you can land properly, for example. It helps obviously increase their strength. And then the psychological benefits of therapy, where if you've ever been injured badly enough to be out of your sport for a while, sometimes it takes some time to really feel confident on, say, an arm or a leg, or to swing a golf club or throw a ball in that same manner that you feel like you used to, and not worry that you're going to get re-injured, and therapy can help a lot with that as well. So, and usually once the injury has healed, say for example, a fracture or something like that, we'll let the physical therapist really guide their return to play. We can say their x-ray looks fine, and then the physical therapist will oftentimes guide that return to play. So some special types of fractures that are commonly seen in sport. These are avulsion fractures, and this is kind of a smaller age group that we see these in, because these are really involve a growing skeleton at a time when they are nearing skeletal maturity. So again, these are not injuries that you would see in a 3-year-old or a 5-year-old. These are injuries you would see maybe in a 13-year-old, for example. There's active growth areas through many parts of the skeleton, and usually that mechanism is a quick cut, a jump, a hurtling motion, for example, to cause an acute stress on a growing portion of the skeleton where a muscle attaches to it, or a muscle or tendon group. And these are common around the hip, around the knee, the ankle, and then sometimes the foot as well. So the main ones that we see from sport would probably be pelvis avulsion fractures. And this is just an example of all the different secondary growth centers that are visible around the pelvis. You can see them all listed here. There's the iliac crest and the iliac spines that are above the hip joint, the greater and lesser trochanters on the proximal femur, where the hamstrings attach at the bottom of the pelvis on the ischium there. So lots of different areas to be aware of that can be injured. And so usually around the hip, these will present as acute pain at the time of the injury. I went to jump and all of a sudden I felt a pop in my hip and I couldn't run anymore. Tenderness over the site of the injury, and then pain with resisted motion, because again, these are where muscle tendon units attach to the bone. And so initiating that motion with that muscle can cause pain, and especially if you're trying to resist that motion, that will definitely stress that area that's been broken. So a couple different examples. Here's an example of an inferior iliac spine avulsion fracture. You can see this part of the bone here that's been just pulled off of the pelvis. So, and this is one similar to that here, a little higher up in the pelvis there. And so here's some arrows. This is a iliac spine avulsion from where the another growth center is up here by the abdominal muscles that actually can pull that off. And then a lesser trochanter avulsion. So you can see on the patient's right hip, which is on your left, that lesser trochanter there has been pulled off of its typical site compared to the normal appearing left hip or the right side of your image. So treatment for avulsion fractures is typically crutches and some either weight bearing as tolerated. Sometimes they might need some protected weight bearing with the crutches depending on their pain and symptoms, but usually these can walk as tolerated with the assistance of crutches for 2 to 4 weeks. And so it depends on their healing time, really. I usually will allow them to be off of crutches after 2 to 3 weeks as their pain allows, walking only. And then range of motion and gradual strengthening. And it does take usually 4, 5, 6 weeks for that tendon muscle unit to reinsert and attach itself back on the bone. And then physical therapy is usually what's important to get these kids back to play. And so physical therapy usually are the ones that will assess their strength, assess their motion, kind of compare it to their contralateral side to make sure that it's equal, and then allow them back to play. The one thing with these is it's very rare for these to need any kind of surgical treatment. I don't have any slides on surgical treatment for these because it's very rare. And I'm going to go back a little bit. For example, this lesser trochanter avulsion, believe it or not, this does not need to be put back in place. The body will do that itself. The muscles and that bone, they'll heal back down like they're supposed to. Now, the x-ray sometimes might look a little bit different, a little bit more prominent because of the extra bone that's filled in there. But in general, these do not need surgery. It's very rare to need surgery. There's a few different types that are kind of outside the scope of this that sometimes need to be put back and fixed, but that's very uncommon, especially around the hip. So we'll go forward. So knee injuries. So these are common sports injuries a lot, and so they're cutting, jumping, pivoting sports such as basketball, gymnastics, or cheer, football. These are a lot of times where you see these knee injuries, but really they can occur in any sport. You can have an ACL tear playing baseball. You can have, those kinds of things. So patella dislocation. So the patella can dislocate, and sometimes people will call this a knee dislocation. A knee dislocation is actually very different than a patella dislocation. A knee dislocation is where the femur and the tibia actually are dislocated themselves, which is much more uncommon, a very rare injury, especially in kids. But that is more of an emergent type of injury as opposed to a patella dislocation, which is really your knee joint is fine. It's just your kneecap popped out of place. That's not to minimize the injury, but it's not the same as, say, a knee dislocation. Here's a picture of what one might look like clinically. The dislocation is almost always lateral. Typically, they do spontaneously reduce, so they might go out on the soccer field and it pops right back in, or they move their knee a little bit to kind of test it and the kneecap pops back in. So occasionally these will need to go to the emergency room to be reduced, but it's usually they reduce on their own. And this is often a non-contact injury. We'll see with some of these knee injuries that contact isn't required to injure the knee like this. So the treatments, immediate treatment would be to extend the knee to see if that helps it spontaneously reduce. But if it doesn't, obviously they would need to be seen at a emergency room and sedated sometimes if that doesn't do the trick. Following that, it's obviously controlling the swelling, ice, anti-inflammatories, bracing for a time. And when we talk about bracing, a knee immobilizer from the emergency room or from the office as an immediate treatment is fine, but a knee immobilizer for any kind of long-term treatment over, say, maybe a week or more would really be something we don't want to see. So we don't like patients to be on knee immobilizers for 3 to 4 weeks. All that does is make their knee very stiff, very painful, and more difficult to help regain their motion and their strength once the injury has calmed down. So knee immobilizers are fine to start, but then we typically will get them into a more of a functional brace as quickly as possible. So a J brace is something that we have in clinic that we use that helps put some force on the patella from the lateral side to keep it from moving laterally, to hold it in a better position. And then physical therapy is really the mainstay of treatment for a patellar dislocation. And that helps strengthen the medial tissues of the knee and keep the kneecap hopefully from dislocating again. So a J brace, this is just an example of a type of brace. And so this kind of helps keep the patella centered within the trochlea on the femur and tries to keep that patellar tracking in a better position. So surgical treatment, again, a disclaimer, this is not a surgery that I perform. Dr. Bray is our main patellar stabilization specialist, and she performs quite a lot of these types of surgeries. But I wanted to at least mention it so you know that kind of thing can be treated surgically. It's usually indicated in repetitive dislocations that aren't responsive to physical therapy. And it's really surgical reconstruction of the ligament that holds the patella over on the medial side. And this is just a picture of that type of surgery where a new ligament is created from the femur, the medial side of the femur, and anchored into the patella. So, and then a few words on ACL tears, because I think everybody who's into sports and sports injuries knows about ACL tears. And so I think it's something that does get a lot of press and a lot of the lay public, knows about ACL tears. So I just want to at least mention it. The incidence does seem to be increasing. It's more common in older teenagers, boys usually around 17 years old, girls around 16 years old as an average. So this is just a little graph here from a study that looked at ACL tears in school-age children and adolescents over a 20-year period from 1994 to 2014. And you can see the blue is female and the red is male. And you can see the incidence here from number per 100,000, goes from around, say, 115, 120, and all the way up, even a spike in 2011 to almost over 180 per 100,000 injuries. And so you can see the general trend for ACL tears is increasing. So causes of that, again, non-contact injuries, twisting, pivoting, landing are usually your main mechanisms, and some kind of pivot and shifting would be an example of a way that would be a common mechanism to injure your ACL. So the females versus males, it is more common in females, and there may be some factors to account for this, and these can include some mechanical or anatomic factors. This picture is from a study with physical therapists looking at, say, two females here doing some single leg squats, and one with her hip, her knee, and her foot nicely in line here with a level pelvis. And the difference with her partner here, where you see a moment from her hip to her knee to her ankle, which is in more of a valgus alignment, meaning that the foot is outward compared to the knee, and the pelvis is dipping on that side. And so, especially as females mature, their pelvises become a little wider, and the angle from their hip to their knee to their ankle does become a little more of a valgus alignment, and that may predispose a little more stress on the ACL. Their ACL may be a little smaller as far as the size of the actual ligament itself. They may have a smaller notch, meaning the notch in the femur, which is where the ACL and PCL are contained, may be a little smaller in females. Again, these are some anatomic studies that have been done that may have a reason for some of the increasing incidence in females versus males. Tissue factors have been examined to see if there's less tensile strength, for example, or if there's any type of hormonal response of the tissues that may make the ligament a little more elastic. And these are things that are still actively being investigated because of this female to male ratio being higher than it would necessarily like to be seen. So here's an example of the International Olympic Committee looking at ACL injuries in different sports, and you can see here that the top 4 sports for ACL injuries: women's soccer, women's lacrosse, women's gymnastics, and women's basketball. And so that's, again, demonstrating that the risk to females may be higher than it is in males, or according to a lot of statistics is higher. And so I don't have a slide on this, but some things for any of our physical therapy colleagues that are joining us today would be well aware of some ACL prevention protocols for high school athletes, especially working on trying to decrease the rate of ACL tears. And so some exercises and functional training that are designed to help with some of these mechanical factors that may increase their chance of their ACL not tearing during their activities. So the history of these, oftentimes they hear or feel a pop. There's usually quite acute pain, and they may still be able to bear weight. They may be able to be helped off the basketball court bearing weight. Sometimes they're not able to, but it's kind of sometimes can be variable. On exam, they usually have a very large effusion, a lot of swelling usually with these, and they have some laxity. So a Lockman test and an anterior drawer test are tests designed to evaluate the stability of the tibia on the femur. And so this is just an example of an anterior drawer test where they are trying to pull the tibia anteriorly, and if it has a lot of laxity without a good firm endpoint, that would indicate that the ACL is not competent, and so it's allowing the tibia to slide forward on the femur in that position. So MRI findings. So on the left side is an MRI of a normal ACL, and so you can see this black line that runs from the back of the femur to towards the front of the tibia. That is the ACL. And so that's something that you see on the MRI. Now, occasionally these can be a little bit difficult to see in a lot of cuts, but usually you can get one cut to see a good outline of the ACL fibers. Now, this MRI image on the right side is a image that shows there's essentially complete disruption of that ACL. You do not see those fibers in continuity, and that would indicate an ACL tear. In addition to that, on the MRI, you might see what we term kissing lesions, where you have some bone injury on both the femur side and the tibia side, and that's indicated by these arrows here, where the bone has some increased signal here at the end of the femur and the top of the tibia here. And so that's usually from that bone banging together as the injury mechanism occurs. And so that's basically a subchondral bone injury, some swelling actually within the bone. And some people might call it, say, a fracture of the bone. There's not really a true fracture line necessarily, but it is impact injury to the bone, and that's often seen in addition to the ACL tear. So treatment, prehab is very important. And so what prehab is physical therapy that's prior to surgery to regain motion and strength. And so that's something that's often done once the ACL tear has been diagnosed to regain their motion, get some stiffness out of there, try and decrease the swelling and strengthen the muscles around that area, so after surgery they have a better ability to recover and perhaps decrease the amount of stiffness after surgery that they might otherwise have. And so typically this would be something from 2, 3, 4 weeks of prehab prior to their ACL surgery. And just a real quick, simple diagram of what an ACL reconstruction is. It's a new ligament. It's not a repair of the ligament. It's making a new ACL. And so these can be done using hamstrings, using the patellar tendon, using quadriceps tendon. And I have a little star here to make sure people know I do not perform ACL surgery. Arthroscopy is never something that I really felt like I was skilled at or interested in. And so luckily we have some excellent partners here that do a very good job of ACL injuries. And again, without a slide on this, ACL injuries in kids who are still growing are very moderately different, we'll say, than ACL reconstructions in adults. And so our pediatric providers here that do the arthroscopy know all of the different techniques to avoid, say, the growth plates, to do things that are growth friendly in a child who has an ACL tear that may still have active growth remaining. Because when you do maybe an adult type of ACL surgery, you do cross the growth plate, and in adults or people who are done growing, that doesn't matter. But in a 13-year-old that may have an ACL tear that has, say, 2-3 years of growth remaining, specialized techniques are needed, and that's what our pediatric sports providers specialize in. So conclusions, hopefully we've seen some things that sports injuries are different in kids than they are in adults. Most of these respond to rest and symptomatic treatment. Most of these do not cause long-term issues. These overuse syndromes or injuries that we talked about, it's very rare to have them cause a long-term functional problem for a kid. And so that's important to remember as we're counseling these children and their families and their parents, that while they may have some of this pain now, and sometimes if they're going to keep playing, they're going to keep having pain. But usually it's a matter of, for most of these things, how much pain can you deal with? For example, Seaver's disease, if they have heel pain, that they do the ice and they do the heel cups and they do some immobilization, and that's still not really working to help their pain, then their choices are to take a break or to continue playing and living with the pain. And they're not harming themselves by doing that.